Welcome to this afternoon. My name is Joachim Haes. I'm working for the global robotics company Intuitive Surgical. And we are hosting today's Masterclass, Health Equity and Robotics, How to Improve Surgery Anytime and Anywhere. This question, what's the difference between being treated on a Saturday morning or a Tuesday afternoon or a Sunday night, is more important than ever, and it needs to be governed and regulated and improved on a European perspective. We've heard a lot about growth, about fairness, about security today, and without a healthy population, nothing of that is possible. In contrast to the big policy we heard about earlier today, we really start from the bottom, though. We really want to build up the topic. And I'm more than proud today to have Professor Katharina Beyer, who's head surgeon of the Charité hospital in Benjamin Franklin, who will report from her daily practice. And she will give some insights into what she would like policymakers to regulate or to improve in order to guarantee that anytime and anywhere. Following her presentation, you will have the opportunity to ask quick questions, but then we will enter into a second talk today that will be delivered by my colleague Tilman Schlick, who is Vice President and Medical Officer at Intuitive, and who will give some insight into the global perspective and about how we at Intuitive are seeing that topic today. Thank you very much for joining me, and give a warm welcome to Professor Katharina Beyer.
Yeah, thank you very much for having me. Okay. When I think of health equity, the first thing that comes to mind is something like a global perspective. I think of global health equity, of global surgery. And global surgery means that every patient can get any operation, anytime, anywhere. And I'm not an expert for global health or for global surgery, but I think it's very important, and we are far away, and that we did not have reached the goal that everyone can get any operation anywhere. So if we move on to a more national perspective, health equity in Germany, the first thing that comes to mind is the hospital density, the differences in hospital density between rural and urban areas. And we have many, many hospitals, around 3,000 hospitals in Germany, but many of them are localized in big cities. And so we have an imbalance between rural and urban areas. And that gets even worse when we consider something like shortage of skilled workers. In rural areas, they lack nurses, and they also have a shortage of doctors. And there are programs to solve this issue, but these problems exist. If we have this health equity in Berlin-Brandenburg, we face these problems of shortage of nurses and also physicians, mainly in the rural areas in Brandenburg. And of my single perspective of the Charité, we are really thankful that we do not have any issues acquiring doctors for our daily work, because the city of Berlin is quite attractive for many of young people, and also many young physicians like to work at Charité, and so we have basically more applicants than we can eventually hire. But I think there is an imbalance between Berlin and Brandenburg in this case. I want to start with a global perspective of health equity, of global surgery. And I would like you to allow these numbers to sink in. 5 billion people lack access to safe surgical care. And many, many deaths worldwide could be prevented by improving access to safe surgical care. And we have many surgeries, 313 million surgeries which are performed annually, but only a very small amount is performed in the poorest 1/3 of the world. And there's another implication with that. If the vast majority of surgeries is done in the high-income country, that means that most of research papers also come from high-income countries, and the results are not automatically transferable to poor-income countries. I have an example. I would like to give an example. Perhaps most of you know groin hernia, these lumps on the groin, sometimes painful defects in the abdominal wall, then it's abdominal hernia, or in the groin, inguinal hernia. And in Europe, we treat those patients with an inguinal hernia repair, and we do a mesh implantation. And we use for this purpose meshes that have been approved for human use in Europe. And because those processes of improvement are pretty expensive, these products are also expensive, and they are too expensive for the poor-income countries. And so our research results of these measures are not transferable to the reality in these countries. And what they do in some of these countries is that they take mosquito meshes from the DIY shop. They shop them and they sterilize them, and then they use them for implants for groin hernia surgery. And so there's only one publication addressing this kind of hernia repair, and all other 100,000 publications are about the standard hernia repair we use in our countries. So, but the talk will be mainly about health equity within the hospital, and what are the implications for a surgical department. Means that every patient must be able to receive any treatment they need at any time, and this has many applications. So the personnel must be available at all times, or at least be recruited within a reasonable period of time. And then there's another issue. Every piece of technology has to be available at all times when it is needed. It's no benefit for the patient if he needs a really complex operations during the night, and there is a brand new robot, the next door, and which could help to improve the outcome of the operation, to improve the technique, to make the operation more precise, and we do not have it available. So the technique has to be available 24/7. So what's about nighttime medical care? Different people come to the hospital at night with different illnesses, that's clear. And so always on weekends or holidays. And the first question is whether patient care is as safe as at night as it is during the day. In medicine, we use trials to answer questions like that. We then compare patients that were treated during the day with those that were treated at night. And as a group often differ in regard of severity of the illness and secondary diseases, we have to adjust these data, and then we can compare the data. And this is a trial like this from the US, a cohort study from the US. Many patients has been included. And we can see, even after correction, that the risk of mortality, which means the risk that the patient dies in the period of 30 days after the operation, is increased in night surgery, and also the risk of morbidity is increased. And the authors of this article, they discuss the reasons behind that, and they find a higher proportion of patients receiving blood transfusion. This is an indicator that the operative technique was not so good. It was a little bit more bloody. And they also see more anesthesia handovers, and that's a very important point, because handovers always mean that information can get lost. And that's their explanation for the differences. So what can be the consequence? The consequence could be we schedule all surgery for the day. That would be brilliant for us as surgeons, because there was not a need to have night shifts anymore. But so there are really emergencies, and I have an example of an emergency surgery. It's acute mesenteric ischemia. That's a disease where the perfusion, the vascular perfusion of the bowel is impaired. And one reason is perhaps an occlusion of a major vessel of the bowel. It's one explanation for the disease. The disease makes peritonitis and also sepsis, and a patient will die if we do not treat the disease. So this is a meta-analysis of many studies, including this topic, and a delay to surgery increases the risk for mortality, for 30-day mortality, to the 2.5 fold. So we cannot postpone surgeries like that. Perhaps a little bit more common surgery is urgent surgery for acute appendicitis. That's an urgency, not really an emergency. It's a very, very common disease in visceral surgery. And the question is, can we postpone operations like that? And we have a little bit more flexibility in postponing operations like acute appendicitis when compared to ischemia. But we must not have a delay more than 24 hours, because otherwise the risk for complications will increase and the risk for mortality will also increase. So postponing the operation can be harmful. We have a little bit more flexibility. We can postpone it to the next day, but it's not possible to postpone it. It's not good to postpone it more than 24 hours. So does a day of the week matter in any case? Are there any differences? And we sometimes talk about Monday casts. Perhaps there are Monday's operations too. I don't know. And there are no clear answers in the literature regarding this question. This is our results from a German registry, and these are for pancreatic resections for cancer. It's a really, really big operation in abdominal surgery. And in this study, the risk of 30-day mortality was higher for surgery on Tuesday. It's not Monday, Tuesday. And the risk of 30-day mortality was higher for surgery on Monday in resection for colon cancer. And the day of the week of surgery did not matter for rectal resections for cancer. So what's the consequence? Is that our schedule? I think not. We have to find out the underlying reasons why this is the case. And in this study, I've shown you the tumors were bigger on Mondays, and in the other case, there were a little bit more comorbidities on Tuesdays, so it's a coincidence. So another question is, are there any other surgeon-related factors? And I often meet patients who say, oh, I'm so pleased that you do the operation because you are a woman, and I read in the tabloids that women operate much better than men. And I always wondered if that was true, but the reality, it's not true. Surgeon's gender has no effect on early complications after surgery. So another thing is a very interesting publication examined the patient-surgeon gender concordance. And this seems to have a measurable effect, especially in women operated on by women. These have the lowest risk of complication. And another issue which has been addressed is the communication in the operating theater. There has been a publication by a monkey researcher, and he had a look at the communication during operation, and he analyzed the communication within the team, and he clearly pointed out that there is, how can I put it, let's say there is room for improvement in the communication during operation. And the communication improves as a proportion of women increases, but it's not best in female teams, but in mixed teams. Mixed teams is the best for the communication. Another thing is music or high noise levels in the operation room. I'm very, very much distracted myself by high noise levels when I'm operating. And there's really evidence that high noise levels have a negative impact on performance and patient outcomes. But what's with music? Many colleagues of mine hear music, listen to music during operations, and there the evidence is not so clear. Classical music, when played with a low or medium volume, can improve the surgical task performance, but very loud music with heavy beats, very, very fast beats, does distract the surgeon from his task, and so increases the morbidity. I think that's really interesting factors. And this is a little bit a fun fact, perhaps. If the surgeon operates on his birthday, this will have a negative effect on the outcome of the operation. Perhaps they start thinking about his birthday presents and the party, and it's not so concentrated. It might be the reason. So that's what all about short-term outcomes. But when we do operations for cancer, then we are very much interested also in long-term survival, because long-term survival means that we were very effective with our operation and we did not leave any tumor in place, and that the lymphadenectomy, the removal of the lymph nodes, has been very successful. And so long-term survival is an indicator for quality of surgery. And I have an example for a very complex operation, and so this operation is so complex that very, very slight differences make a huge impact on the patient outcome. And this is esophagectomy for esophageal cancer. And that's a video how that happens. If anyone has esophageal cancer, we have to remove the vast majority of the esophagus and the upper part of the stomach. And then we take the stomach and form a gastric tube from the remaining stomach, and we pull it up into the thoracic cavity, and then we suture the stomach tube to the remaining esophagus. That's a really, really big operation, one of the biggest we have in abdominal surgery. So, and this is about this typical esophagectomy. Are there any surgeon-related factors? So, surgeon age. It's perhaps an indicator for something like maturity or something like that. So, but surgeon age really matters. Surgeon age peak performance is between 52 and 56 years. I think it's a little bit more about experience than about age, because I'm in my mid-40s and I have another 10 years to reach the peak performance, if that was true. But I think it's an indicator that maturity is very important, and that you have to operate on many cases to reach perfection. So we have learning curves in operation, and this complex procedures. It's very clear that these learning curves are especially long, probably just over 50 cases, but possibly we have to think that's over 100 cases you have to do that you can gain proficiency. And then another factor is the annual case volume. And there's a strong correlation with long-term patient survival and the annual case volume of the hospital. That means first the learning curve of the surgeon matters, and then the annual hospital volume is more important. So that's about a learning curve, a surgeon's learning curve, not only for esophagectomy, but for any case of operation. You can see competence on the x-axis and confidence on the y-axis. And unlike competence, the feeling of being able to do the procedure well is not linear. You start without being able to do something, and you know that you cannot do anything. But after a few procedures, you can't really do more. You do not have really more competence, but you have much more confidence. You think you have already reached perfection. And this is a very dangerous zone, because this is a zone where many mistakes happen. And so a structured training program is very important for these operations. And then competence and confidence match again and reach a plateau. And that might be for esophagectomy more than 100 cases. Yeah, that's very, very much. 119 cases. You have to perform 119 cases to get proficiency. And that's just to put it in the context. In Berlin, around 300 esophagectomies are carried out each year in 8 different hospitals. So this means that there are only very few surgeons who will be able to do these operations. Very, very good. So, and here you can see the impact of the annual case numbers on mortality. And there's also many, many evidence that the annual case numbers of the hospital really matters. And you can see in this that 45 esophagectomies per year are necessary to reach an acceptable rate of mortality, of postoperative mortality. And in Germany, such complex operations are regulated by law through minimum case volumes. A hospital that performs the operation, even though it falls below the minimum volume, will not be reimbursed by the health insurance companies, meaning that it will be left with the costs and will no longer offer the operation to the patients. Until a few years ago, the minimum volume was 10 resections per year per hospital, but as this did not correspond to the published data, it was increased to 26 resections, and that's the actual number. The number you have to do 26 resection minimum per year, and then the insurance will reimburse the cost for that. So you can see here very clearly that in-hospital mortality is connected to the annual case volume in these kinds of operation. And there are other analyses showing that it's not only so much the competence of the individual surgeon what matters, because the complication rate does not really differ in this study. What is really important is that it's kind of a failure to rescue. If a complication occurs, then the team is not ready to treat the complication. And this is one of the main reasons why minimum case numbers and centralizations are key. So we will see what the hospital structural reform will look like and what we will change. But I think probably it shouldn't stay the same, but the government is on the right track in pushing this forward. Annual case numbers are really, really, really important. And this is a last point. We know that minimally invasive surgery has huge advantages, especially for such complex procedures. And instead of a very big incision in the abdomen and in the chest, we make very small incisions and do the operation by means of laparoscopy using a camera and some very, very small trocars. And there is evidence that minimally invasive procedures reduce complications in esophagectomy. And so it's recommended to do it. And, but we have more. And there are some limitations of laparoscopy. And the robot-assisted surgery is really a benefit for us as surgeons and for the patients also. The hand movement is the same as an open surgery. And the robot does the movement as a patient for us, but we do the movement in the console. And it's very, very nice for surgeons because we can do the operation in a very relaxed way, and it's also nice for the assistant, the RA nurses. They are really relaxed on this photo, perhaps a little bit bored, but relaxed at least. And yeah, the operations are more precise because we have we have a very, very good view in a three-dimensional view, and we can make very, very small movements, and the robot is very, very exact in transferring the movement to the patient. And so we think that this is really a key point for the quality of our operation. And so we have to conclude that we have to implement this 24/7 because it's the technology we need 24/7. And we did it. I did it in our department. And there were some issues. At first, the robot seemed dangerous to the nurses because they thought it's too complex and it's very difficult. There were many buttons on the robot, and that's a little bit, yeah. They thought it was dangerous. And after a few procedures that ran perfectly, the procedures often seemed boring to the nurses because they had little to do after docking. They had to dock the robot, and then they could sit and wait until the operation was finished. But in the event of an emergency conversion to an open procedure, the entire team must be perfectly trained. And I think that's really important. You have to make sure that every member of the team has perfect training, and then you can do that. And so regular training of the entire team is really important, and then you can implement a system around the clock. So that's my last slide, and I think our treatment will be even more individual in the future, because 100 years ago we made our decisions based on the experience of the most experienced colleagues we knew. And then we switched to evidence-based medicine. So we just looked at many patients, and we did research on many patients, populations, and we draw our conclusion based on the average patient. But in the real world, the average patient does perhaps not really exist. And nowadays we focus more on not so much a one-size-fits-all procedure, but more tailored procedures. We look on many aspects, and we generate many data, and we have to work together with data science management and something like and guys like that to provide a really personalized medicine. I think that will be the future. Thank you.
Thank you very much, Ms. Beyer. So we learned that if you need surgery, you should go to a large hospital during daytime, not on a Thursday, and find an experienced surgeon of about 50 to 55 years. Are there immediate questions from the audience? No? Yes?
Do you think you can run that totally remote, such surgeries?
That's a really tough question. I don't think so. From a technical point of view, it would be possible. But from an ethical point of view, I think the problem would be, at the moment, I could only do that if I was sure that the team in the OR is able to do something like emergency conversion to an open procedure. That happens one out of 100 cases. It's very rare, but it happens. And we have to make sure that the team can manage that.
Thank you very much. Tilman, the floor is yours.
Welcome. Death is probably the worst complication that you can experience as a surgeon, as a patient. And this was probably the very first thing that I learned when I joined medical school and went into my very first position as a young surgeon in University of Mainz. And it's honestly a tough lesson that you learn as a young person. You see all these patients going through a hospital to different disease stages, and after different procedures, you see them on a normal ward where they recover from long operations. And sometimes they're very pale because they had bleedings, and we call this anemia. And later on, I became responsible in the emergency care where patients deal with greater complications such as sepsis, organ failure, and death. And all after surgery, after an invention in the best intention. So maybe this was also a moment for me to learn respect for surgery. And at the same time, where MIS treatment, so minimal invasive keyhole surgery, came up, was a time to learn about access trauma. Minimal invasive means keyhole surgery, and later on, an evolution of keyhole surgery, which we call robotic surgery today, was invented. You can imagine that all these different surgical techniques have a different complication rate and a different amount of blood loss and many more factors. I also learned what happens, what you need to do if you are technically not able to complete your case. We call this a conversion. So you convert your one technique down to the very standard one, which is open. And I also saw these patients that had robotic surgery that sit the very next day in their bed with normal clothes on, and they tell you, I want to go home. In difference to others that had surgery open, and they wanted to stay longer. So there's a difference. And I need to tell you honestly, I'm still thrilled by the fact that this broad band between day case surgery, where you send people home immediately after, versus a death and all for the same procedure. Maybe this was a moment when I learned that desire to change something in surgery as such. Because the problem consists and continues to exist. To put this in perspective, in Europe, about 1 million deaths every year due to complications. And later, when I then finally joined healthcare industry, I was very pleased to see that they also have a same mission. I really believe that we as an industry, we have an opportunity, we have an obligation to transform patient experience in helping surgeons and collaborating with them. We work hard around the world to do 3 things. Please join me in following the idea to provide better technique or technologies to enable better outcomes. We want to keep patient safety top of mind always. And we need to help advance health equity as a third focus point. Let's have a look into these 3 things. Since almost 30 years, since our inception, we focus on helping and working with surgeons and providing innovative technologies to improve patient outcomes. You see different versions of a same model, which is minimal invasive surgery combined with a computer built into it, helping surgeons during the surgery. And these technologies were validated by evidence, by scientific papers. They are the fundamental understanding of the value of our technologies. It helps us, but it helps also customers and healthcare systems, politicians, decision makers, to really understand the impact of minimal invasive care. 43,000, that's quite a number. And as this is so important for us, I would like to look a little bit together with me, join me in looking into the data. If we pool data together, we call this a meta-analysis, and we do this for several procedures, and we only calculate in the good publications. We find about 78 out of Europe. And you look into those points that really matter to a patient. We heard about blood loss is important. We heard about the idea to convert back to open. So the rate is important for patients. And of course, a good example, length of stay. And many more factors. Let's have a look how that looks like. We always understand ourselves to compare laparoscopic, so handheld surgery, to robotic, and to the former standard, which was open surgery. You see, for example, versus open, that the likelihood that you need to transmit blood to the patient because there was a bleeding is 80% less likely if you use a robot. There's fewer conversions in both if you open to compare to open or if you compare to lap. And yes, you see at the very bottom that robotic surgery may take longer. But I would say if you can achieve those other advantages, it's time well spent. Now, this directly needs some explanation, maybe. Think of it this way. If a robot would not exist, we would have more conversions. So an additional 130,000 conversions. If you translate this further, this would translate in prolonging hospital days, that patient need to stay longer. And if you calculate it, it's quite a significant number, as well as people that need to return back to the hospital because they experience more complications after they were sent back home. So what we see here, there is a real impact whether or not you use technology. And it's a fundamental thing. It's our understanding of the value of our technologies. And as data are always presented in numbers or in statistics, let's not forget that behind each number, a person stands, a person that we call patient, with his emotions, with fears, and with expectations. And of course, we want that they have the best possible experience that they can have. When I see a patient that comes the first time to the hospital, I always think about safety. Hopefully we can send him or her back in a better shape that he or she came in. So we do as a company. Also for us, delivering an optimal patient care requires ensuring patient safety being top of your mind, always. And yet, healthcare industry has a lot more work to do here. Believe it or not, there's industry that have a perceived higher risk and that their real safety record reports. Look, in aviation, we do see a statistic around 1 out of 1 million chance to get harmed. In a hospital, this is different. 1 out of 300 risk to being harmed in healthcare. So all of us, including Professor Beyer, myself, hospitals, the healthcare industry, as well as the society, we all are passionate about playing a role to change these odds. We believe that everyone deserves to receive a safe and high-quality healthcare. That's why we work so feverishly to improve it. Preclinical, so pre-launching a product to the market, we do a lot of work here. Risk analysis, product validation, statistics. This gives us the confidence that the product does what we will say it will do. Post-market, we'll provide a structured and a measured technology training pathway for surgeons, for physicians, for our care teams, because we know that better training supports better patient safety. And we share best practices. In robot-assisted surgery, we have a lot of service and support teams that share and help our customers to optimize their programs. Take standardization. Standardization is a good example because the more you do something, the better you get. You saw the numbers. And finally, we built together with our customers an enormous database in order to build out our technology and to support them on the next level. Thanks to the high bar, we believe that we can definitely contribute to patient safety, but we also recognize it is not just our responsibility. Industry, hospitals, and people, all they deliver care, they all need to work together to deliver that. And if everyone deserves a better care, this requires dedication and focus on it, where everyone, regardless of race, ethnicity, disability, sexual orientation, gender identity, and other factors, can attain a full potential for health and well-being. However, this is not the case. This is not the reality everywhere and across the globe. Inequities do exist. research shows that social determinants of health can be more important than healthcare or lifestyle choices. Even though health life expectancy has increased globally, it has not increased everywhere equally. And that translates directly into a difference of 18 years. And also, death due to surgical complications have declined over the past 50 years. They still remain 2 to 3 times higher in these groups. And in order to improve attention to this persistent inequities, the American Journal of Medical Association published an article in 2020-22 proposing the addition of a 5th aim, that of advancing equity of care and renaming the quadruple into the quintuple aim. The reasoning behind that was that none of the previous aims can be fully met without health equity as an explicit goal. This is Tom. Tom just turned 70 years old when he suddenly experienced an enormous abdominal pain. It is 9 p.m. somewhere in Europe. Arriving at the hospital and waiting nearly 3 hours to get seen by triage, learned that he has a significant elevation of inflammatory signs in the blood. And another hour goes by until he experiences and gets his CT scans completed. The diagnosis becomes pretty clear. It's an acute sigma diverticulitis close to perforation, so something that you better treat before you have finally the perforation. Perforation means bursting of the colon and causing greater trouble that you like. Long after midnight, Tom enters the OR. The team manages to do and start out laparoscopically and needed to convert to open because, indeed, meanwhile, the problem got bigger than expected. A resection was done, the cleanup was done, and some bleeding occurred intraoperatively, and Tom received 2 transfusions. Postoperatively, a week of intensive care, some sepsis involved, and after that, he took about 2.5 weeks on a normal ward. Imagine this patient coming with the same diagnosis, the same story, the same symptoms at 9 a.m. This time, Tom is lucky. He falls into a fully equipped Da Vinci team, a surgeon that is fully trained, an OR team fully trained on Da Vinci. The case can be completed fully in a minimal invasive fashion. It's a 1 week of postoperative stay, and Tom can return back home. This is, I believe, an example which is all too true for an inequity of health. But it's certainly one we can do something about. Around our core technology, we build a world of products and tools and services to help customers to overcome these barriers. The integrated ecosystem, this is how we called it. So it's not just a robot, it's a lot of tools around that help to address some of those barriers that fuel health inequities in a few primary ways. We know that Da Vinci surgery reduces variability, regardless of when and where and by whom care is delivered. Intelligent technologies like telementoring, later telesurgery, help to shorten the learning curve of MIS. And this reproducibility extends to emergency cases. Think about Tom. There's a lot of consulting services and teams that help, and also an ongoing evidence generation that helps customers to speed up in adoption of technologies. And finally, we provide education for patients, hoping to empower them to get the right time and the right treatment in the right place. In the end, it's surgeons, it's care teams, it's hospitals, it's governments that drive fantastic ideas around the globe. Ultimately, they do it in so many different ways. Have a look. In New York, in the Bronx, you have a number of trauma centers, and this one is the biggest. It has about 160 annual admissions every year. A lot of uninsured patients. Imagine the traffic that this place has. Accidents, trauma, emergency around the clock. Dr. Cheryl Moulton, the chief of surgery, considered herself to be a maximal invasive surgery. So she did every case in an open fashion. You could even say that she likes open people. And after she made a commitment and said, this needs to change. And she said, okay, I will move my procedures to a more minimal invasive indication and surgery technique, and I moved to Da Vinci technology, and ever since, the number of patients she was impacting is enormous. She's now offering 24/7 a minimal invasive service to their patients, and don't you think that really changes patient experience? I believe so. To share one example quickly out of Norway, if you suffer endometriosis, that's a tough thing because it can take years until you get diagnosed. And even worse, until you get surgery, takes a lot more time. This team managed to do an initiative to operate in 2 days, 24 patients. And that was what they called the Northern Light. They saw the light by understanding that a proof point that you can do it by a mind shift to treat more is something that they needed. So after that, they were able to maintain a 20% higher throughput of patients by just changing their mind. No additional investment was necessary. For us in Intuitive, health equity is not a new concept. It's a part of our vision, and it applies to all patients. I wholeheartedly believe that we have some keys to significantly transform patient experience. It's really exciting. There's just the technology. It's that piece that does the access trauma into where a surgeon operates. And you see on the left side a machine that only needs one single hole of 3 centimeters. And this technology, and this is maybe a secret, is surrounded by so many more technologies. And they all are based on data, digital data. Think of it as a computer in the OR. You need AI and ML for it to visualize things that you cannot see before. That you need to find a way how to deal with data. You can change the way how surgeons learn surgery if you transmit this to simulation. And of course, it helps you to build a virtual reality that again trains surgery to make it better. Telecollaboration is just one more aspect that we will see more coming. But with all that technology, let's not forget what matters most. It's that intimate relationship between a patient and a surgeon, because it can be a really healing one. Thank you.
Thank you very much, Tilman. This was fascinating. Professor Beyer, would you join us for some final thoughts and questions? Is there an immediate question, understanding to Dr. Schlick? No, that's not the case. Please come in between. Go ahead.
But I think this would increase the gap between the poor countries and the rich countries. Because with that technology, I would expect that the life expectation for the richest ones become longer, and that technical equipment will not be available in poor countries, right?
I agree with you. That problem existed already before the phase of robotic-assisted surgery. It's a reality true for so many other things, including pharmaceuticals. But we do have a way to work on these things. Telementoring in the future, telesurgery be an option. I agree with you.
And I would like to add that this product, this robotic technology, is available at least in all European countries. So all 27, and that's not a sure thing. Even in the lower earning Eastern European countries, that technology is in principle available. And this is leading to the first question, the EU Commission has suggested that healthcare should be better transferable in Europe. So at the moment, they think about flying a patient from Bulgaria to Paris or to Berlin for their surgery. Do you think that is a good start? Is it enough? Or what would be your suggestion for the EU?
I think, remote surgery would be perhaps an answer to that. But we, as I said before, we have to make sure that the team, perhaps wherever it is able to deal with complications. And most of these in those countries have a very good training in open surgery. For us, there is perhaps sometimes a threat that we perhaps do not really teach open surgery anymore because we do so many things by means of laparoscopy or minimally invasive surgery or robotic surgery. So we teach our residents doing everything in a minimally invasive approach, and perhaps sometimes we will only teach them in a robotic approach, and then they won't be able to deal with that complication. And that's another thing in low-income countries, because they mainly operate with open surgery, and so they are well trained in this specialty.
Yeah. Thank you very much, Tilman. And maybe could I have a second microphone?
My answer to this very fair point is that it's more based on reality. We do see within Europe that patients fall. They want to be treated by someone that is able to do the procedure very often, or is supported by technology, or ideally both. So I'm in favor of that German healthcare reform, where we build centers that have high volumes, as you saw in the numbers, that this really makes a difference for patients, and that is what I'm very supportive of.
Thank you for your talks. One of the things that comes through both your talks is that the medical industry has a lot of mindset shifts that are necessary and that need to come about, because it also has a lot of absurdities. For example, just the fact that, we wouldn't make an intern work for 16 hours a day, but we'll make a doctor work for 16-hour days and make him do, or her do, very impactful surgeries. What do you think are the main mechanisms for getting these mind shifts in an industry that desperately needs it?
That is indeed touching sort of a miracle, What makes people change? I believe that in the medical world, we're very much focused about evidence-based. I think you touched on this. People need to see a paper. Show me the proof point. And in some way, you need to understand, to produce papers like this take a long time. Clinical research can take years, and to get it published and until it gets accepted. And so I believe that innovation, and that is maybe an associated question to it, gets not adopted by hard evidence. There's something else. And I told a story out of Norway. They need to experience it themselves. They need to sit down onto the technology, see what it does, and it gives you a quite good understanding whether it can help you or not. And same for other change processes. Sometimes you need to build a lighthouse that you can copy, that you, if they do it, I can do it too. So it's basically learning from others that may do that effect that you touch on. I don't know what you think about that. So it's a sort of a miracle. I agree with you.
Okay. I would like to get back to the possibility of remote operations. And you said you wouldn't see it in the near future because of ethical reasons, but I thought, okay, isn't it also a chance because the doctor on site would at least be able to do his way of operation, which he would do now without the possibility. So, and the patient would not be flown from Bulgaria to Berlin, which saves also time maybe for the patient. So don't you see a strong opportunity there? There's also the possibility of like tele-mentoring or something. So what's your case on this?
Yes, I do, and I think especially tele-mentoring would be a really great idea because we could do proctoring remote and add some extra support for surgeons who are in the learning curve, and perhaps in the middle of the learning curve at the beginning there has to be some. It's not a good idea to do that remote, but in the middle of the learning curve it would be, it would be a good idea. But I think if we do it in a patient, we have, from an ethical point of view, we have to make sure who takes the responsibility for the patient. I think that would be the one who is on the console, who does the remote surgery. And if I'm responsible for a patient, again, I must ensure that the team in Bulgaria or where else is able to deal with anything that can occur. So, yeah.
Maybe just to add some technicality to it, technically it's possible. That has been proven in 2001. We know today that in China it already happens. They talk 6G. We are far away from 6G, right? We look and hope to get 5G. But technically it's possible. I believe that it will help us in the future. We start small with telementoring. It's one way of delivering care. And I believe that we will solve these ethical questions that are fair and true. I want to know who gives me a surgery. And a patient has a right to say yes to that. And this is the way, at least, how we think today. He or she must say yes to it and agree to it and accept the personality. As we saw, there's differences.
Thank you. Just because it pops up in my mind before I come to my question to what you just discussed. I had the opportunity in last autumn to be part of a delegation to Israel to visit the major hospitals there and to get some insight into the healthcare system there. And of course, this country is very much, let's say, different to ours because there's a little bit different, let's say, atmosphere of urgency. And there they do that, especially when it comes to, soldiers, for example, who are harmed, etc. Or because they also kind of course, still care about also the area where the war takes place, where some organizations actually do help. So it was impressive what is possible when things are very much connected. And I'm looking forward to see how this evolves and how much of this can probably swap also over to us. To come to my question exactly. So I founded Patients for Digital. I had a break of 2 years now, so I'm getting ready again these days. So I founded Patients for Digital out of an intrinsic motivation to actually form the future with regard to healthcare experience specifically. So I very much like that you put focus on that. in my experience, so I also provided an excerpt on Professor Gocke's book on das digitale Krankenhaus, exactly on the patient-doctor relationship. So in Germany, we have the situation, and this can be good. We have a very strong trust bond between the patient and the doctor. It's not the same everywhere. One could also say this is probably for change, some kind of a burden. It depends on how to tackle that. So my question would be, can we come to a situation like in Spain where the patient experience and the factor that the hospital has certain surgical machinery, for example, or robots like you, actually have an impact on the hospital to make decisions? So to go further, for example, or let's put it differently. Do you see a chance that the patient's voice actually can be a driver in getting this technology more into practice, or would you say it's a hurdle?
Yeah, I think it's already the truth. Many patients come to my outpatient clinic, and they explicitly ask for robotic surgery, and they say, "Oh, I read on your homepage that you offer this kind of surgery, and I want robotic assisted surgery, and that's why I chose you." So I think that's already the truth.
Yeah.
I give you an example in breast surgery, where decision making is not only on the surgeon who tells the patient this is what you get. In breast surgery, because it's a very delicate and sensitive subject, patient and surgeons decide together. And that is leading the pack. It's different in esophageal resections. You know, a patient is not so much about the esophagus. They don't even know where it is. So it's a different ballgame. But I think breast surgery, just to give you an example, yes, this is coming, and this requires that patients need to learn and be empowered to know what is relevant, how can the problem be solved, and then find a decision together with a surgeon.
Thank you very much. This is actually something I noted for our next panel, which will be on health literacy, definitely, because patients need to know what is available. And that's not only about time and place, but also, and I've made some notes, about minimum case numbers, about technology, training, and not least, about money in the health system as well. Thank you very much for joining that session today. Thank you very much for speaking today.